Hello, everyone. Happy Friday. Happy first Friday of December. Mike Ackerman here, genetic cardiologist at the Mayo Clinic and director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic and the Winland Smith Rice Sudden Death Genomics Laboratory. Here on behalf of Alice Laura, our CEO of the SADS Foundation. So if you think you're at SADS Live versus whatever social media platform you've joined us today, great to have you. We are the largest and arguably the only nonprofit advocacy organization devoted to the SADS conditions, to families affected by a SADS condition like long QT syndrome, CPVT, Brugada syndrome, ARVC, ACM, whatever you find, if that's your letter and set of letters, hopefully you find us at the SADS Foundation your home. I hope you had a wonderful Thanksgiving weekend last Thursday, 8 days ago, and getting ready for a great weekend. I think we are at SADS Live number 133. I lost count. I was going to look that up as we're getting ready for Question and Answer Friday. Today's your question, and I see Nathan has one in the queue, and so please go ahead and post yours. Before I start taking your questions, a couple of announcements for you. First, let me show you this. I think you're going to like this picture. Some of you might remember this. This was the so-called Doctor's Prom Promise from about 16 years ago. That's Stephanie, and that was Stephanie then, and this is more recent. And the reason I'm sharing you Stephanie is it is Stephanie's 33rd birthday today. And Stephanie, at age 33, happy birthday, Stephanie, was one of my very early patients in fellowship who received her heart transplant at age 9. And she's now 33 years old. That's a wonderful husband, Trevin. Mom and dad are amazing. I love Stephanie. And that picture was me dancing with Stephanie at her prom. And then she went to Hope College, and to keep the Hope College theme going, a picture of one of my athletes, yes, with long QT syndrome. Yes, even type 1, who has a scholarship commitment to swim for Hope College. So congratulations. I just saw her and saw her letter of intent being signed. So congratulations to her. Maybe she might be one of the ones we'll interview during our athlete focus and exercise focus next year. In January 19, 2024, we'll have a focus on with athletes. We have right now coming up December 10 in 9 days, a Compassionate Friends candle lighting ceremony, and our team will put up some information for you if you want to remember in a special, tangible way a loved one taken far too soon and too early, and tragically for some of your families. You can connect there on the Compassionate Friends candle lighting and our healing wall ceremony. And then with that, I see questions flying in, so let's do them. Nate's asking, are there any news related to Brugada syndrome? Well, that could be a long topic. There's new news all the time, but I would say maybe some of the newer awareness is that most of Brugada syndrome is not a genetic disease. That's good news in some ways, because it means that we don't have to constantly be thinking about it lurking through the family. We have argued that, and I think I first said it over a decade ago, that most of Brugada syndrome is not genetic. And we said that because we were never finding new genes. And the number one gene for Brugada syndrome, the SCN5A gene that builds that sodium channel, after all this time, is still only responsible for about 20% of Brugada syndrome. Many of the other published Brugada genes have kind of fallen out of favor with not enough evidence to declare them a true convincing Brugada gene. And so most of Brugada syndrome does not have a genetic cause. And we're starting to become more aware of thinking of Brugada syndrome as an isolated RVOT-opathy, a cardiomyopathy, a congenital heart malformation of the right ventricular outflow tract. And that's why things like RVOT epicardial focused ablation can be an effective therapy for some individuals with Brugada syndrome. So maybe that's some new news. I guess another related to Brugada syndrome, see if I have the picture of that, is we just finished hosting our fourth Winland Smith Rice visiting professor at the Mayo Clinic, and that was, let's see if I have her. Yes, I can have her for you, and that links it. Dr. Georgia Brugada. And so Georgia from Barcelona, Spain, was with us 2 weeks ago and served as Mayo Clinic's fourth Winland Smith Rice genetic heart rhythm clinic visiting professor. So that's enough for Brugada for now. Tracy, her son is 2 months. Oh, I love that age, and has long QT. You had a denervation, left cardiac sympathetic denervation done 13 years ago. It helped you a ton. What is the age you can have the procedure done? Well, Tracy, I love the question. I'm a little biased because we've done more denervation surgeries than any other program in the world at Mayo Clinic. So we have a large experience with that treatment option. It's not for everyone, though. But in those who need it, age does not matter. We've done it as young as 4 weeks of age. We've done it as old as 80 some years of age. When you do it young, it's because the disease is nasty and we need to add more protection. So we seldom offer denervation instead of beta blocker just because I don't like the idea of beta blocker. I don't want my child getting beta blocker and then do an upfront denervation. That may change in the future, but mostly we will do denervation as an alternative for beta blocker in those who hate their beta blocker at a little bit older time frame. But from an execution standpoint of the denervation surgery, we can do that at any time. SADS Foundation given the reminder. Thanks, SADS Foundation and Anna. And Amy sharing, joining the chat with Timothy syndrome, LQTS8, and hope everyone is doing well. And it's great to have Amy and our colleagues with Timothy syndrome. Some of you know, because the Timothy syndrome community is very close, that we have special patients with Timothy syndrome that I've had the privilege of caring for many years now. And we even have a close relationship that we've helped grow, the TS Alliance, the Timothy Syndrome Alliance. And when we think of Timothy syndrome, then the only definite Timothy syndrome gene that has been proven is the gene CACNA1C that builds the heart's L-type calcium channel. And so mutations in that gene that builds that calcium channel, certain mutations can give true Timothy syndrome, and we call that gene then TS1, Timothy syndrome subtype 1. Other mutations in that gene give only QT prolongation, no evidence of Timothy syndrome, and then it gets called LQT8. And so there is a little bit of a distinction that we need to make sure is that not all LQT8 is Timothy syndrome. All Timothy syndrome due to the L-type calcium channel is QT prolongation from that calcium channel mutation. And so I like to keep them apart because the natural outcome of true calcium channel mediated Timothy syndrome and true calcium channel mediated long QT syndrome only, or LQT8, have very different pathways. So welcome, Amy. I'm delighted that you joined us. And Julie's sharing that she's confused. Julie, how can Julie be confused? Anybody who sends me this cannot be a confused individual. So again, I love my hat, Julie. Thank you. Um, and that's probably a good spot for it right there. So, but Julie's confused about the need for an AED for a diagnosed, treated child. Also, how big does a child need to be for an AED? So I love the automatic external defibrillator, Julie. It is a very interesting thing. We've had our colleagues from LifeSure on. They're a wonderful for-profit advocacy organization that helps our families secure one. And AED is part of my treatment recommendation as part of the family safety gear, but it's really just like my fire extinguisher at home, my seatbelt in my car. I wear my seatbelt. I still have never been in an accident, so technically I've never needed my seatbelt, but I wear it. And so the AED is part of that Boy Scout Be Prepared. And I was just learned, I used to always do two fingers, probably why I wasn't a great Boy Scout, failed before getting to Eagle. But that the Boy Scout Be Prepared is actually three fingers. So now an almost Eagle Scout patient of mine from last week taught me that. But it's really part of that Be Prepared. So I tell my families that yes, it's part of your safety gear, that for my athletes, it's a mandatory part of their athlete gear, and yet they're probably never going to need it. So in the case of my athletes, I've returned 800 athletes to their sport. They all have the AED as part of their safety gear. The number of AED usages among my treated 800 athletes, zero in 23 years. How big? You can use the AED at whatever age. For this child, small child, you get the pediatric pads. We just had our first experience not too long ago where I've told the families, your AED is much more likely to get used on the official of the game, the referee, the umpire, a spectator in the stands, and it happened. When we had him on our program, where the family saved that referee's life when in his early 60s, he had a triple coronary, classic older age heart attack that triggered a danger rhythm that the AED, the kid's AED for his long QT, ran out, retrieved, and used. So that's the AED. David's asking, with a long question, I'm going to try. Consistently experiencing frequent multifocal PVC skip beats. Holter, is that another way of saying someone has MEPPC syndrome? If not, what other criteria needs to be present? You have the variant N1325 S in the sodium channel. You have normal QT intervals. That's interesting, by the way. Your younger sister died 23 years ago and 22 years ago when she was 14 at age 6 from LQT3. You're now approaching 40, yet to be tested. Whew, that's a lot. So what's very interesting, and so sorry about your sister's death, is that mutation, asparagine 1325 serine or N1325S, was one of the very first mutations discovered and published back in 1995 in the SCN5A encoded sodium channel. And that mutation in those owners gave, just like in your younger sister, true and isolated QT prolongation. In other words, LQT3. So that has for always been thought of as an LQT3 exclusive mutation. But now you're sharing that you own the variant and yet your QT interval is normal. And that is a more recent understanding that we've had about this exact same variant, which, like other sodium channel variants, can display itself in different ways in different owners. So one owner can show QT prolongation, LQT3. Another owner can show a normal QT interval, lots of ventricular ectopy, multifocal PVCs on ambulatory monitoring. In other words, one of the newer sodium channel disease syndromes of MEPPC. And so it sure looks and sounds for that individual that might be its declaration. The two younger daughters, all children of somebody who owns a mutation must have genetic testing, family specific variant testing, and must have an ECG to make sure we've looked already to see if they're exhibiting objective evidence of that heart condition. So be sure to talk with your physician, get checked out, explore with your healthcare team about getting your daughters tested. They need to be tested. And then more information about the candle lighting day. Sharon does having your first episode. She's LQT1, age 47. It was a really extensive exercise in the past. When on sertraline, puts you at higher risk of further episodes compared to someone who has never been symptomatic, no longer on sertraline and no further symptoms. My consultant said I was classified as higher risk, and I just wondered on what basis. So great question, Sharon. So in general, what determines your risk in LQT1 are several factors. Your past, what has it done in you so far? So a recent naturally occurring faint that sounds LQT in origin is a warning sign for a future faint. The only higher risk predictor is if that faint went on to sudden cardiac arrest and you needed external defibrillator rescue. That's a high risk factor. Other high risk factors are, what is my QTC number in the morning, meaning my 12 lead ECG? Is it long, super long, not so long, hardly can tell? That helps with your risk. Are you a man or a woman? Men are at less risk than women, pound for pound, for LQT1. What kind of LQT1 mutation do I have? Where in the potassium channel does it reside? And so all of those would be baked into the soup to decide your risk category. Now, what's not on there is an episode from a QT prolonging drug like an antidepressant medication like sertraline, trade name Zoloft. So I personally don't use that as a risk factor. There's no evidence to use something like that as a risk factor. A natural faint, yes. A long QT interval, yes. A LQT1 mutation that localized to certain real estate in the potassium channel compared to other territories, yes. And so a careful assessment of the known risk factors helps us classify our patients. And I try to put all of my patients and convey to them on a scale of 0 to 10, 0 being basically non-existent risk to 10 being spooky risk, to try to help that family have an understanding of what my risk forecast is, because then that helps us understand why we are assembling the particular long QT specific, CPVT specific treatment strategy to neutralize that assessed risk level. Sue, great question. Sue, mom, LQT1 with family history on 20 of Nadolol twice a day, has a 2-week-old baby on 0.6 milligrams per propranolol 3 times a day, weighs 5.6 pounds, been pumping and saving breast milk, genetics on baby pending. Is breastfeeding safe for the baby? Absolutely. So whether you are on the Nadolol or not on the Nadolol, the amount of Nadolol secreted in breast milk just is not that much. And if baby sees some of that Nadolol and doesn't own your LQT1 variant, because hopefully the test will come back negative, that would be wonderful, then that amount that the baby is going to see isn't going to hurt baby. And so, yes, you should, if you need to be treated, you should stay on your treatment and breastfeeding is best. So enjoy that time with your baby. They grow up really fast. My baby, my last, our fourth, she is 20. So time flies. Um, Amy's asking again, Amy is our friend with Timothy syndrome and may need a pacemaker. Has anyone ever had to get one, and how did they do? So yes, I mean, if we need a machine, pacemaker and or defibrillator, usually in Timothy syndrome, the concern would be sudden cardiac arrest, counter protection, or our counterattack. Then that includes a defibrillator capability. And what Amy is getting at is unique to Timothy syndrome, so not true at all of LQT8 only or any of the other long QTs, Brugada, CPVT, is that anesthetic management in a child adult with Timothy syndrome is very delicate. So it has to be dealt with very carefully. And we do that, in fact, doing that today as we speak in one of our patients with Timothy syndrome. So it's really meant, but that anesthetic risk, if you will, is not relevant to almost all of our other families. So we can do almost all anesthetic procedures for almost all things, wisdom teeth, whatever, for almost every condition represented in the SADS families, except for Timothy syndrome, where we have to be thinking quite carefully about the anesthesia strategy for their care. Type 1 was Tracy. Yep, yes. And that's correct. So, Amy, in order to be called Timothy syndrome genetically, the only gene that is responsible for genetically proven Timothy syndrome is CACNA1C. Now, can you have Timothy syndrome clinically and a negative genetic test? Yes. And that just shows that we don't have all of Timothy syndrome accounted for genetically. And so we have the primary gene, the only definitive gene to date. And I'm not sure what percent it accounts for now. It's probably on the order of 50 to 60, maybe higher, of Timothy syndrome is explained by mutations just in that one gene, CACNA1C. That same gene, of course, is the cause of LQT8, or calcium channel mediated long QT syndrome. Dark is wondering if there is any clinical trial for LQT1 for foreign patients. Not that I know of, and not yet, but soon potentially. And specifically, the one clinical trial that is enrolling patients in the United States that I'm aware of is the SGK1 inhibitor drug LQT1213 from the company Thrive Therapeutics. Full disclosure, I'm a consultant for them. We have partnered with them at Mayo Clinic to help develop this drug. Now, that trial is enrolling patients in the United States. And so far, a couple of patients, so we're in the early stages with LQT2 or LQT3 have been enrolled. Based upon those results, then the next trial would get extended to other countries, particularly other countries in Europe initially. Louise, hello there. I'm great. Thanks for asking. What are the most common signs, symptoms of Brugada syndrome? When do you suggest a genetic test? Well, the number one symptom so for all of these SADS conditions, long QT, CPVT, Brugada syndrome, not ARVC for a moment, is the way you get a symptom is if that Brugada heart, CPVT heart, long QT heart goes out of control into the dangerously fast bottom chamber rhythm called ventricular fibrillation. If you do that, if the Brugada heart does that, you will know that because it shows that in one of three ways. Way number one, you suddenly faint. And then 10 seconds later, you wake back up because that danger rhythm stopped on its own. And then that was just a where did that faint come from kind of thing. Symptom number 2 is you fainted, and then 30 seconds, 40 seconds later, you have a full head to toe generalized seizure. And that's because you fainted 30 seconds ago, but the danger rhythm is still going like this. So blood is not getting perfused to the noggin, and the brain says, where's the blood? And it gets electrically ticked off, hence the seizure. And that's why some patients with Brugada, CPVT, long QT have been called, misdiagnosed as epilepsy, because that's what they were observed doing their seizure. But the seizure stops, the person wakes up, because even 30 seconds later, the rhythm caught itself. Symptom number 3 is not just suddenly fainting, but heading towards tragedy through sudden cardiac arrest, whereby it's not going back to normal on its own. The only thing that will get it back to normal is 911 chest compressions and the automatic external defibrillator, where you push the shock button to restore order. Short of that, there's not miniature symptoms like, oh, my heart just did something. Is that my Brugada acting up? Almost never. In Brugada, because it's often to have those episodes at night, that's where people will describe the so-called agonal breathing or nocturnal agonal breathing, because the witness hears the strange noise of the person doing their cardiac arrest movement, and they hear that agonal, scary sounding breathing that alerts them that the person next to them is having a Brugada danger rhythm episode. When do you get the genetic test? In anybody, the guidelines say anybody where a clinician is going to call you Brugada syndrome, diagnose you as Brugada syndrome, genetic testing is indicated, even though the genetic test only explains 20% of Brugada syndrome. And that's because if you are that 20%, we now know the name for it for you. We have the marker for your brothers, sisters, mom, dad, children. And so even Brugada syndrome, even with the yield of the genetic test at 20%, even though most Brugada syndrome is not genetic in a simple single gene way, genetic testing is indicated nevertheless if somebody's thinking about that as the diagnosis. Sharon stating a fact that our QT shortens during exercise, and that's good. That doesn't mean a lot. That just means it's not likely LQT1, because most LQT1 patients don't shorten during exercise. Another question wondering about whether IRBBB affects QT length. IRBBB is incomplete right bundle branch block, and it does in the sense that when you have a conduction delay, right bundle branch block, that causes your QRS number to be long, that sort of then inflates the QT number. And so some people talk about doing a wide QRS adjustment to that number. One of the interesting things is, though, that patients with true long QT syndrome almost never have right bundle branch block or left bundle branch block. They almost always have a normal QRS duration. Amy's asking, and so I'm just taking the liberty, since I'm taking these straight in line. Some of you who might be keeping track are saying, hey, you're giving Amy a lot of questions. So normally we just do one for the question and answer session, but we are going to grant Amy a December 1st bonus. And she's wondering, is it advisable for LQT8 with bradycardia as well to avoid exercising and swimming and things like that? Well, it's a good question. There's no data that I have been convinced by or generated that would say that swimming or exercise is dangerous to the LQT8 fuel. So I like to think about an explosion, whether you do the faint or the seizure or the sudden cardiac arrest. In order to have a long QT, CPVT, ARVC, Timothy syndrome, LQT8 explosion, you need to have flammable fuel. That's your long QT mutation. That's your CPVT mutation. And these different mutations have different flammability indices. And so in long QT syndrome, like we were talking about for Sharon for risk factors, the longer your QT interval, that tells you that your long QT fuel is more flammable than somebody whose QT interval is completely normal. But in order to have an explosion, you have to have more than just flammable fuel. You need a spark to ignite the fuel. And in CPVT and LQT1, for example, the spark, a common spark, is exercise, adrenaline, thrill of victory, agony of defeat. And those sparks can ignite that fuel if that fuel is flammable. And of course, if that syndrome is unknown and therefore untreated, it's easier for the explosion to occur than if it's known and we have dialed in a treatment program. And so for LQT1 and CPVT, we know that that fuel can be ignited by sports, exercise, adrenaline, whereas in LQT8, there's no evidence for that. In Brugada syndrome, there's no evidence for that. In ARVC, there's some evidence for certain ARVCs, like if your name of your fuel is PKP2, that is more explosive, more aggravated, more annoyed by long distance endurance training sports than others. Now, speaking of sports, just a reminder that we're going to have a great program, two great programs next year, January 5th and January 19th. And hopefully 19th will include an interview with one or more of my athletes. Sharon just sharing that her specific LQT1 mutation is G269S, and that just happens to be a very well-known LQT1 variant. So every family, so like all of our LQT1 families on SADS Live, your LQT1 is going to have a different address, a different misspelling than hers, because most are unique to the family. There's some repeaters, of course, now that we have so many families. And we know that the different LQT1 mutations intrinsically have different sort of flammability characteristics. If that analogy resonates, if that makes sense for you, keep it. You can use it. If you don't like it, just ignore it and forget about it. David's follow-up is about getting the daughters tested. Yes. Where we'll talk more about MEPPC. Relatively new. Yes, it is new. So David, good news is there is both a European MEPPC registry being built and a North American one. We have started it in our program. In fact, one of my PhD students, Kevin, his entire PhD thesis is devoted to this MEPPC. So you're right. We don't talk about it as much. So MEPPC is the sodium channel is fascinating. Certain mutations in the sodium channel do LQT3. About 5 to 10% of all of our long QT families are LQT3. Other mutations in the sodium channel do Brugada syndrome. Remember, 20% of all of our Brugada patients are SCN5A, sodium channel. Then there's the new kid on the block, or the newer kid on the block, where mutations in the sodium channel doesn't give you long QT, doesn't give you Brugada, but gives you this phenomenon of multi-ectopic Purkinje premature contractions. And we're starting to figure out in what way does the sodium channel get damaged from a pathobiological perspective that moves it to an MEPPC fuel rather than a QT fuel, LQT3, or the Brugada fuel. So we'll try to add in that. It's difficult when MEPPC is probably, well, it's not as rare as Timothy syndrome. So Timothy syndrome, as a perspective, is about 1 in 2 million people. Sodium channel long QT syndrome is about 1 in 20,000 people have LQT3. And MEPPC is probably somewhere between those two. Let's say probably around 1 in 100,000. Cortez, my son, 5 years old, so pre-K or kindergarten, had cardiac arrest about 5 months ago. Tomorrow he'll have his first football training. And that stresses a little bit. So, well, we don't know the why, or at least we're not told the why here, but it looks like your son has been diagnosed, has been treated, has a treatment program in place, and now is getting to return to doing the activities that he loves. And so all the best with that. Sharon's updating that she's LQT1. So I think also we have to go back to that stress test of hers and take a look at that, because most LQT1 patients will not have their QT shortened during stress testing. So that's where the detective work comes in all of our families, is really making sure the pieces of evidence are lining up together appropriately. Let's see, I got 3 minutes on the counter and more have come in. If we did not get yours done, we will add them to our last SADS Live of the year 2023 on December 29. So let's see, before I run out, this next one. Elizabeth, 32-year-old daughter is genetically positive for LQT3. So we were just talking about LQT3. Just met a genetic doctor who repeated her test, saying new info may prove her misdiagnosed. I am confused. Is this right? We are SCN5A. I think that's right. She has never had an episode found on ELF at 8. Something. Okay. Not sure what that meant. ICD implant done. Well, what the genetic person could be referring to is that there are irrefutable disease mutations in SCN5A that no doubt is LQT3, like our family earlier, the N1325S SCN5A family that can do LQT in the daughter, LQT3, and MEPPC in the other individual. There are other mutations that are irrefutable Brugada mutations. And then there are variants in the sodium channel that are variants of uncertain significance. They're unclear, ambiguous. And sometimes there can be variants that were once called disease causing, but over time we've learned more, gotten smarter, realized some things, and those have been demoted or downgraded. And in fact, there was a recent webinar that we did that you should go to the archives. And I think the title of it was, "What's All the Fuss About of Us?" And it shows you the challenges with the interpretation of a genetic test result. So it sounds like your daughter and your team may need to assemble a team to go back to first principles of how robust is the diagnosis. What do the ECGs make the diagnosis by themselves, with or without the genetic test result? Well, how certain is the grading of your specific genetic variant and get a current uh, readjustment. Sounds like a diagnosis was made 24 years ago, and much has happened in these past 20 some years. Well, we're going to archive the rest, and we'll start with the one on the last program of the year. And SADS team will cue it up with the question from Renee: is a positive genetic test a pre-existing condition? That's a really important one, and I can't do it justice with 10 seconds on the counter. So I'll have you join me, please, 4 weeks from today, December 29, for SADS Live New Year's resolution. And don't be surprised if Anna reaches out and we assemble and start the program with a little video thing of your New Year's resolution. So 4 weeks on the counter. We'll see you then. Until then, have a wonderful weekend, this first weekend of December. And I can't wait to see you again.